Assessing for cardiac deterioration. Vital signs are exactly that. They are signs, not just measurements. They offer vitally important clues about your patient's condition. So what constitutes vital signs? Of course, the vital signs we are all familiar with are the hemodynamic parameters, which include blood pressure, pulse rate, respiratory rate, temperature, and oxygen saturation. But vital signs are more than just these. Vital signs also includes assessment of the skin, mucous membranes, and nail beds, assessment of peripheral and central perfusion, assessment of the JVP, the jugular venous pressure, auscultation of heart and lung sounds, and a neurological assessment. So let's have a more detailed look at hemodynamic parameters, starting with blood pressure. Remember that blood pressure can be normal or high during the early compensation phase. Late deterioration phase will usually lead to hypotension. Normal parameters for blood pressure are systolic pressure between 100 and 140 millimeters mercury, diastolic pressure between 60 and 90 millimeters mercury. Now, let's review pulse rate and volume in the context of cardiac deterioration. A normal heart rate is between 60 to 100 beats per minute. A tachycardia, greater than 100 beats per minute, may be seen in early compensation phase due to sympathetic stimulation. Bradycardia, less than 60 beats per minute, may occur in late phase of deterioration when compensatory mechanisms fail. Remember to interpret the pulse rate in context with the patient's own baseline parameters. What about assessing respiratory function? Assessing respiratory rate in the early state provides one of the most vital clues of deterioration in any patient. Tachypnea is an early sign in any deteriorating patient. The normal respiratory rate is 12 to 20 breaths per minute. We consider it to be significant when a respiratory rate is above 22 breaths per minute. Are you assessing your patient's respiratory rate every time you assess your patient? Respiratory function is not just assessed by looking at a number, the respiratory rate. We need to also observe the movement of the chest for any abnormal movements, for instance unilateral movement of the chest, hypo or hyperpnea, and any signs of respiratory distress, such as nasal flaring, use of accessory muscles, and increased work of breathing. Let's continue by looking at oxygen saturation. Normal values are between 90 to 100%. Why do we no longer aim for a value higher than 95%? Studies have shown that supplemental oxygen can be harmful to the body. Thus, oxygen therapy should only be considered when hypoxemia is present. When we perform an examination of the skin and peripheral perfusion, we look for decreased perfusion by assessing color, temperature, and moisture of the skin. Skin turgor should be assessed to determine the fluid status of the patient. We assess peripheral pulses to determine if they are absent, weak, normal, or bounding. This can't be done with the oxygen saturation probe. It's essential that you actually feel the pulse to assess the volume as well as the rhythm and any irregularities. When we look at peripheral perfusion, there are 4 parameters that we look for. We look at the color of the skin and the nail beds. We look at the temperature of the skin, we look at capillary refill, and we look at the moisture of the skin. If a patient's perfusion is normal, the color of the skin will be pink, the temperature will be warm to the touch, the capillary refill will be less than 2 seconds, and the moisture would be dry. When there is inadequate arterial supply, the color will be cyanotic or pale, the temperature will be cold to the touch, capillary refill will take longer than 2 seconds, and the skin will be clammy. Inadequate venous return will have a flushed, mottled or purple skin color. The temperature will be hot to the touch. Capillary refill will be rapid, usually less than 1 second, and the skin will feel excessively dry. Assessment of the JVP or jugular venous pressure is conducted by examining the neck veins for increased venous pressure. A raised JVP may be an indication of right ventricular failure, fluid overload, increased right cardiac pressures, pericardial constriction, tricuspid valve disease, or congestive heart failure. Auscultation of heart and lung sounds and a neurological assessment should also be done in your normal vital sign assessment, as these give a comprehensive clinical picture of the patient. There are 4 early signs of deterioration in the cardiac patient. These give you vital clues that the patient is going to or may already be deteriorating. These 4 vital clues are 1. Tachycardia, 2. Tachypnea, 3. A low systolic blood pressure, and 4. Altered level of consciousness. But remember that blood pressure may be normal or even high if the body is already compensating. And remember, any change in a patient's mental status is always significant. So now that we've reviewed the basics of how to assess a patient, what are the possible causes for deterioration in the cardiac patient that you should be thinking of when assessing your patient? Possible causes of cardiac deterioration include myocardial ischemia and infarction, low cardiac output syndromes such as pulmonary embolism, cardiac tamponade, and tension pneumothorax. We're going to discuss these possible causes now, as well as look at the management of chest pain.